Fatima, we can start the meeting. Please start.
Okay. So good evening all. I hope everyone is having a wonderful evening. So today we are gathered for a free webinar on molecular biomarker identification for right treatment decision in NSCLC organized by IAO, which is the International Association of Oncology, in league with scientific partner Bioleagues worldwide and supported by AstraZeneca and Medgeno. So once again, welcome to all of you. Thank you for spending your time with us, and welcome to all our keynote speakers, to all our participants and everything. So I'm sure that the session is going to be wonderful with us. Now, before we start the session, I would like to say a few words about our scientific partner. Bioleagues Worldwide is a non-profit, which is a globally recognized professional association that operates under the TechnoRite Group. It serves to propel and fuel all innovative works of research with immense potential in the fields of healthcare, life sciences, pharmaceutical sciences, and the medical sciences in general. In this capacity, Bioleagues Worldwide has been directly responsible for a significant amount of the revolutionary developments that have taken place in these fields over the past few decades. Now, a few words about our organizers. International Association of Oncology is one of the world's leading professional associations for medical oncology and life sciences professionals caring for people. IAO is a non-profitable professional or association meant for research and development in the field of medical oncology and life science. IAO is an international forum for researchers, academicians, doctors, and practitioners for sharing knowledge and innovation in the field of healthcare and life sciences. IAO aims to bring together worldwide researchers and professionals, encourage intellectual development, and providing opportunities for networking and collaboration. IAO delivers to its members the industry's most essential technical information by organizing conferences, workshops, annual convention meetings, and provides networking opportunities for both locally and globally. Members have the ability to stay current in their chosen profession, connect with peers, and invest in their future. IAO provides a broad-based home for members and societies who are interested in aspects of the medical oncology and life sciences, together with companies, hospitals, government organizations, pharmaceutical company researchers, and university researchers. Now, I'd like to say a few more words about our supporting partner, AstraZeneca. AstraZeneca is a British-Swedish multinational pharmaceutical and biotechnology company with its headquarters at the Cambridge Biomedical Campus in Cambridge, England. AstraZeneca is leading a revolution in oncology to redefine cancer care. Our ambition at AstraZeneca is to follow the science to discover, develop, and deliver life-changing treatments that increase the potential for cure. Now, a few words about our another organizer, who is Medgeno, and our partner. Medgeno is a genomics and Medgeno is a genomics and clinical data-driven diagnostics and drug discovery research company founded in 2013. Medgenome is the market leader in genetic diagnostics in India and offer comprehensive diagnostic solutions to researchers, doctors, and hospitals. We have expertise in simultaneous genome sequencing and clinical data analysis to identify genetic mutations across several disease areas. Medgenome operates the largest College of American Pathologists accredited next generation sequencing lab in Southeast Asia, housing cutting-edge genome sequencing platforms such as Illumina's NovaSeq, HiSeq-X, HiSeq 4000, and 2500, MySeq Extender. MedGenome is the largest NLGS lab in Southeast Asia with an in-house cutting-edge genome sequencing. Platforms such as MedGenome is capped, well-accredited laboratory as well. Now, it gives me immense pleasure to welcome today's dignitaries and keynote speakers who will be talking to us about these topics that we have been giving the free webinar today on. So first, I would like to welcome Dr. Ullas Batra. He is currently working as Senior Consultant and Chief Thoracic Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center, New Delhi, India. Welcome, sir, to our webinar, and I'm sure the session is going to be very informative. And over to you, sir.
Thank you. Thank you for the nice introduction. Although the spelling of thoracic and Rajiv Gandhi was a bit on the wrong side of that, but yes, I should have seen it before. Till that time, I share my slides. Just give me a sec. Let me just share my slides. Okay, here we go. Okay, so without wasting much time, I'll start with my presentation, which is identification of EGFR T790M mutation post the TKI therapy, whom to test and when to test, and that is what I have to speak about. And my first reactions when I first saw this topic about whom to test and when to test about EGFR T790M was the FLORA trial. It was not the AURA trial, it was the FLORA trial. You know, FLORA trial has really established osimertinib as the first-line treatment in the management of non-small cell lung cancer. And this is what I think, this is the medical oncologist, and I presume this was the osimertinib, and you know, there's a love-love relationship between medical oncologists in a stage 4 non-small cell lung cancer with osimertinib. My subsequent reactions about the real-world usage of osimertinib in first line, and I found out yes, not more than 5% or 10% of people would use the original osimertinib in the first line. So definitely there is a point in testing for T790M. And the picture on the right, what we want to believe, suddenly turns to a picture over here, which is why exactly you should have 2 points, and that is why we'll be discussing more about the AURA trial rather than discussing about the FLORA trial right now. It is always important to start with, I was told to test only 2, whom to test, when to test. Now I'll be telling about whom to test, what is it, when is it, where is it, why and how of T790M testing. And I'll give you a clinician's perspective onto that about how do we test for T790M mutations. Let's start with why. Why do we start? We all know the success stories of first and second generation TKIs over here. And what we basically know is that, the first and second generation TKIs do lead to an increase in the performance, in the progression-free survival. However, there is no overall survival advantage. That what does that basically mean? That basically means the honeymoon is short and the honeymoon is over. The honeymoon is over pretty soon than you actually can imagine. It's almost what I would say is a typical honeymoon which lasts in a very nicely marriage around 9 to 10 months. I'm sure Dr. Ghanshyam Biswas is smiling right now and proving me wrong. The honeymoon with him is lasting throughout and throughout. But typically the new age couple, the honeymoon will last for around 9 to 10 months. And then, you want to see what exactly is happening. So why does the honeymoon get over? Why does the honeymoon with first and second generation TKIs get over? That is because of the T790M testing. So the T790M testing, either alone or in combination with EGFR amplification or in combination with other EGFR point mutation or small cell lung cancer differentiation, is a major important factor in the resistance, which is the resistance which is seen to first and second generation TKIs. So what exactly is T790M actually? And if there are some residents listening over here, this is a very nice cartoon. So look at this. This is basically the first generation TKI. it reversible binds to the EGFR. It inhibits the binding of ATP to this. So if the blue one prevents the binding of the yellow one over here. If you have a T790M mutation where threonine gets substituted for methionine, you have an altered structure in which gefitinib or afatinib or dacometinib is not allowed to bind to this pocket, and that is why the first and second generation the drugs do not act. The third generation TKIs, that is osimertinib, actually has a better structure and is able to bind to this, and that is why it is much more effective in treating T790M. So that's the basics about why exactly T790M important. So let me put the clinician's perspective first. What all can be done to treat T790M? One obviously is you give chemotherapy. The second one is you continue the TKIs and you add chemotherapy. That was the IMPRESS trial. Obviously, we'll talk about the AURA trial. And the third, which we'll talk about, is combining osimertinib and anti-angiogenic agents. That is the ETOP trial. So let's look at the IMPRESS trial design. This was the earliest trial of Tony Mock, which is not really much more spoken because this trial was a negative trial. However, I have a strong problem with telling people that there is something called a negative trial, because every trial teaches us something. And this was a trial in which people who basically progressed on the first generation TKI were randomized into continuing with gefitinib plus chemotherapy, or they were given only chemotherapy. Now, this was the concept of oncogene addiction, and we were almost hoping that Tony Mock has wonders that what he did with the IPASS trial will come and do the same wonders. Unfortunately, this trial was negative. The PFS was exactly similar. In the T790M, it was 4.6, 5.3. In the non-T790M, this may have a point, but it was only 5.4 and 6.7. So the trial was exactly a negative trial. So there is no role of continuing gefitinib and adding chemotherapy to it after the progression on first-line TKI. So this was a negative trial. Now that brings us to the osimertinib AURA3 trial design. Now again, in this trial, osimertinib was compared to platinum pemetrexed, and again the pemetrexed maintenance was allowed. And what it basically showed was that a 4.4 months PFS, which was achieved with the only chemotherapy, that was the standard arm of the IMPRESS trial, and this increased to 10.1 months. That is a 70% reduction. But mind it, and if there are medical oncologists over here, there's always the PFS versus OS debate. And if you follow them up for a long time, this was what was presented in WCLC 2016. And what happened in 2019, or I think it was 2019, the AURA3 overall survival was a negative study. That means if you progress on first generation TKIs and then give osimertinib and then give chemotherapy, or you give TKIs and then chemotherapy and then osimertinib, by and large the results are by and large the same. The overall survival was not very different. Why was that so? Because a high population of them crossed over to the osimertinib arm from the pemetrexed platinum to the osimertinib. That is the most important thing. What is the relevance of this to today's topic? The point here is, please test for T790M again and again, because if you have a T790M mutation, your survival is going to get much more higher. As long as the patient receives chemotherapy and osimertinib, things are going to be absolutely fantastic. Now, osimertinib, so you gave chemotherapy plus gefitinib was not better than chemotherapy. Osimertinib was better than chemotherapy. So, medical oncologists, we always want to learn more. What this study did was, and this was presented at the ESMO virtual plenary, that we added Avastin to osimertinib. Again, we thought, ABCP regimen or a relay trial, maybe bevacizumab plus osimertinib will be almost equal to osimertinib. Unfortunately, this trial also was a negative trial with an HR of 0.96. So, gefitinib plus chemotherapy is not better than osimertinib. Osimertinib plus bevacizumab is not better than osimertinib. The important thing is that patients should be tested for T790M, and if they are positive, you basically go ahead and give them osimertinib followed by chemotherapy. So that was the story in the clinical ideal world. Now let's talk about the real world scenario. It is very easy to say this happened in the clinical trial. Now let's exactly see what happens in the real world. So there are 4 major studies which basically I have taken. And there's a study from the Indo-American Institute. There was a study from our institute. There was a study from TMH, and there was a study from TMC. Now, India is a democratic country. You know, we say we are extremes. Similarly, in T790M, you have a positivity rate of T790M is 28.50 versus 54.80. The confidence interval is very, very, very wide. So why is it that we are having such a difference of the concordance rate of testing for T790M? I'm just going to present our data. This data was presented by Dr. Mansi Sharma, and we were the co-authors for this. This was our study basically, in which we identified a T790M by ddPCR in patients progressing on first and generation TKIs. So this was the data basically in which we found out that patient who had progressed on first and second generation TKIs, we tested for T790M. If they were positive, we gave them osimertinib. So out of, I think we had 500 patients, 251 patients had progressed on first or second generation TKIs, out of which liquid biopsy, we got 131 testing done. A tissue 74 testing was done. 42 patients had both liquid and tissue tested. Now, please remember this testing has been there for, this data is from 2015 to 2019. So maybe there is a slight variation of the data, and 46 patients did not undergo T790M testing. That is very, very important. Maybe these people were there in the earlier, maybe the patient performance status became so bad that they were not very fit for getting a T790M testing. So our percentage positivity of T790M by ddPCR was 50%. 49.61% was found to have a secondary T790M. Now, what happened? What we did analysis was, if there were efficacy was there, what was the efficacy if the if osimertinib was given to these T790M people? And we had a median progression-free survival of 6.9 or 7 months, and the median overall survival was 9.3 months. However, this data, there are small numbers, and we should be taking this data with caution, but this is the real world data. Now, if we see how many patients, what was the data of osimertinib in patients who had a T790M by liquid biopsy, it is exactly 7.23 months. So it does not make a difference whether you detect T790M by tissue biopsy or you detect it by liquid biopsy. The by and large, our data says that the data is by and large the similar. The median PFS and OS is by and large the similar. So why this discrepancy between the clinical test trials and the real world setting? And that's my favorite song, Why This Cola Very Deep. Why should there be a difference in the T790M rates of positivity and between the real world and the clinical scenario? Now that's a slide. The T790M testing is not singularly dependent only upon the T790M testing. It has it has got a 4 interplay of things which are involved. First, we should select the right patient. Do not start testing for T790M in a de novo population. The right patient, I'll come to it. The right time to test, you don't test for osimertinib for T790M in patients who are progressing on osimertinib. The right time to test is very, very important. The right test, the tissue biopsy or liquid biopsy. In liquid biopsy, whether you have COBAS or whether you have beaming or you have NGS or you have ddPCR, the sensitivity of the test is very, very important. And the right interpretation of the test. I mean, that's something which is very, very important. The right patient, the right time to test, the right test, whether it is tissue biopsy, liquid biopsy, and the right interpretation of the test is very, very important to get a good T790M result and to get somewhere probably closer to the clinical world setting. Now, very important. This is for all my medical oncology practicing words. This is something which is a very, very practical thing. So let us say, if you have what has been suggested by the Australian guidelines basically is, once you test for T790M, don't only look for T790M, look for the primary mutation as well. There's a 90 to 95% chances that your primary mutation will be present in that. But if it is absent, and if your T790M is also absent, then probably these are the ctDNA non-shedders. Remember, if you do not shed it well, the point is, if I am speaking, and I'm sure most of you are not listening, I can't say that that the information did not percolate. The information will percolate only if the computers are on, if somebody is trying to listen to it. So if the tumor is not even shedding the DNA, then how will you get a T790M or a primary EGFR mutation? So if you have a primary mutation positive, T790M positive, fantastic. If you have a primary mutation negative, T790M positive, no worries. If you have a primary mutation positive, T790M negative, no worries. But if you have both the primary mutation negative and the T790M mutation negative, I think you should take this point with a pinch of salt, and maybe probably do a tissue biopsy, or maybe look at the volume of the disease. Maybe it's just one or two bones which are basically increasing. So maybe it could be something which is a non-interpretable test. Again, uninformative T790M results are not true negatives. So this was a Brazilian study which was published in IACLC. What they basically found out was there were uninformative 37% results. Now, when these were followed up and you got a repeat biopsy done, liquid biopsy done, 6 out of these 10 patients actually became informative. 5 patients became T790M positive. That is not important. Whether you are positive or T790M and negative, it is important only for the patient's perspective. From the science perspective, please look at whether the ctDNA is enough or not, whether the patient is a true shedder or a non-shedder. And I'm sure my molecular pathology oncology colleague will definitely dwell onto this. One, I said, look at the results properly. Look at the report properly. Also, look at the baseline target lesion size. I'm going to discuss it more about in my panel discussion. Now, very important, this was the Aura extension and the Aura 2 study. And what they basically said was, if you have a 1.5 by 1.5 centimeter tumor with maybe a 1 or 2 mildly metabolic active brain bony lesions, or if the patient is failing only in the brain, maybe the tumor is not shedding the enough ctDNA. If the tumor doesn't shed enough ctDNA, there is very little chance that you're going to get a good ctDNA for the primary or the EGFR mutation. So the time to testing is also important, and that can be done also. We have to see whether the patient's baseline size, how much is it? And if you have a patient whose tumor size is less than 2 centimeter, 3 centimeter, not a very heavy load of disease, probably it's worthwhile in continuing the same TKIs and do a early repeat evaluation for that. This was again a case report which basically says, is there a correlation between tumor burden, ctDNA shedding, and an uninformative result? The more the tumor do you have, the more the chances of ctDNA shedding, the more the chances that you will pick up a informative T790M. I'm not saying you will get a positive T790M. I'm not saying that. Maybe you will get a informative, and the patient can be given osimertinib, which is an absolutely fantastic drug, an oral drug, and probably that will help the patient achieve a better PFS and the overall survival. So various guidelines, you should follow the Jackman's criteria for acquired resistance to EGFR TKI. What I actually want you to concentrate basically is, please test only, we don't treat a report, you treat a patient. These were the guidelines in which I was involved. And point number 5, the T790M testing should be performed only when the oncologist decides to change the treatment. A lot of times we have seen that if you have a PET scan report saying mildly metabolic active disease, interval progression, and we start asking for T790M, it comes as negative, we give chemotherapy, patient does not actually get the repeat T790M testing done, because we always tell them, yaar, ek baar to ho gaya. We don't want to do. So so basically the point is, please test for T790M either by liquid or by tissue only when you are planning to change the treatment. That for me is the most important thing. And the tissue biopsy versus the liquid biopsy conundrum, this is something which is very, very important. Will you treat on the tissue or a liquid biopsy? So this was the Aura 7 trial. Plasma from the Aura trial was basically sent for beaming. There were paired tumor results were positive in 216. 18 were positive in plasma, not in tumor. 47 were positive in tumor, not in plasma. What they basically found out was that irrespective, and that is what I showed you in our study also, irrespective of the fact whether you have a T790M in liquid or in tissue, if you have a T790M, it doesn't make a level of, it doesn't make whether it is 0.02% or 0.5%, although the higher one is always important. If you give osimertinib to them, they will actually do very, very well. So it does not matter whether you get a T790M in tissue or in liquid. If you have a T790M positive, you are going to respond to the study. That was about the aura, but there is something called as Astra study, which was again seen whether osimertinib, this was a study. And this is what I would like to show, very, very important. So we talk about India. I showed you 50% of people underwent liquid biopsy. In Asia, actually, by 2019, the tissue was a more predominant way of testing. 37% of the patients actually had undergone a tissue testing, and liquid was done in 53% of the people, actually 59%. In the Europe, 55% of the patients actually had blood, and tissue was only in 38% of them. But what happened if you had a result positive? By and large, there was no difference. Either you have it for the tissue, or you have it for the liquid, or you have for pleural fluid. If you have a T790M present, it does not make a difference. You treat with osimertinib, the results are going to be by and large the same. So what is the T790 algorithm? An excellent paper that I saw from the Australian group. You start testing for, so first of all, you test only when you want to change the treatment. Absolutely no harm in treating a patient beyond progression, no worries. When you want to change the treatment, start with the testing for the liquid. If it comes as positive, give osimertinib. If it comes as negative, you do a tissue biopsy and then test for T790M. If it comes positive in that, probably give osimertinib. If it comes negative, and then you can actually go ahead with chemo. One thing which I have done again and again is now I have started sending a repeat, liquid biopsy specimen in 3 months time, 6 months time, just to make sure, just to see whether T790M has come positive over there. Results have never been that great, but yes, 10 to 15% of people are actually picking up more T790M mutations. I guess we are learning more on the job actually as we are doing this. So key takeaways: ctDNA sample with a negative sensitizing mutation or a T790M can be considered uninformative. The amount of ctDNA is more in patient with an increased tumor burden. RECIST criteria needs to be used. Liquid biopsy first, positive treat, negative do a tissue biopsy, and then test for that. So, I was thinking about how to conclude this. I think it is the art of medicine in combination with the science of medicine that is there in the T790M testing. And I hope no surgeon is listening to this. The practice of medicine is that of a thinker, and the practice of surgeon is actually part of a plumber. And I really hope that my hospital surgeon are not listening to this. With this, thank you. Thank you for the invite. And I'll be happy to take any further questions. Thank you.
The doctor would be happy to take any questions from you all.
Or we can even discuss in the panel discussion that we have. So anything.
You can have your questions for later for the panel discussion, or you can have it addressed in the chat box also for anyone. Okay, so if anybody has any questions, you can park it later during the panel discussion. Now, moving on from that. So I would like to introduce our next speaker. Who is Dr. Soumya Surath Panda. He is currently working as a consultant medical oncologist, IMS, and some hospital, Bhubaneswar, India. Sir, please welcome to our session, and the floor is all yours. So please go ahead.
Yeah, thank you. Can you hear me?
Yes, sir.
Okay. So after the beautiful talk by Ullas sir, we'll discuss the challenges in detection of Tcentm mutation post-progression. So I'll be discussing on the Tcentm test experience and the challenges for biomarker testing and feasibility of a rebiopsy post-progression and the tumor heterogeneity and early testing for Tcentm, and then I'll conclude my talk. So this is the number of samples, 14 samples we had sent and 7 came positive. This was the tissue sample, and from total
Sir, your voice is not audible, sir. Dr. Soumya, sir, your voice is not audible.
Dr. Soumya, your voice is not audible. Dr. Soumya? Dr. Soumya, are you having any issues with your network? Kindly excuse the interruption. Our speaker seems to be having some network issues.
Very sorry for the interruption. We will proceed for our next speaker.
Okay, thank you, Kanchana. So I would like to apologize for that interruption. So on that note, we would like to proceed with our next speaker. So I would like to welcome our next speaker, who is Dr. Gyanasham Biswas. He is currently working as an Executive Director and Medical Oncologist, Sparsh Hospital and Critical Care, Bhubaneswar, India. Sir, the floor is all yours. You can go ahead with your presentation.
So good evening all. So I hope my slides are visible.
Yes, sir.
So since there was a problem with Dr. Soumya, so let me go through the case capsules. So we know that today's topic is molecular biomarker identification for right treatment decision in non-small cell lung cancer. So these are certain real life cases. So if you look at, so Nobel laureate speaks. So this gentleman is a former director of NIH and former director of NCI. So one of the major advances we have had is a deep recognition of the complexity of the cancer. It's not one disease, it's lots of different diseases, and every single cancer is different when you look it on a genetic level. So this is Dr. Harold. So after a beautiful talk by Dr. Ullas, so if you focus on lung cancer, so lung cancer today, so it is one cancer which has now many faces. So if I start my oncology journey, so one of my MBBS classmate father died of lung cancer in 1999, who was being treated at AIMS. My own grandfather died in non-small cell in 2002 when I was doing my DM in Tata Memorial Hospital. My school's teacher's wife died of adenocarcinoma lung in 2009. An LIC executive diagnosed with adenocarcinoma lung with the EGFR exon 19 mutation in 2009 is still surviving. I'll discuss this case. You see, so these red line focus, so with changing in years, so the terminology and understanding of the biology of lung cancer has changed. So one of my MBBS classmate who was diagnosed in 2010, he's an ophthalmologist by profession. So he was diagnosed, unfortunately, non-smoker, diagnosed with adenocarcinoma lung, so with a brain mets. And we lost him 2 years back when he was diagnosed with again T790, and he was on osimertinib for 2 years. Another veterinary doctor with ALK positive on crizotinib for 7 years now. Another doctor by profession, pediatrician, a retired elderly gentleman, during COVID was diagnosed with exon 19 and on osimertinib. So these are certain scenarios. And if you see, these are some slides I've taken from Dr. Vivek Suvaiya. So in COVID, besides the pandemic, you can see it's lots, almost 10 plus approvals in lung cancer. If you talk about May 6, 2020 and May 2021, you can see so many approvals in a non-small cell lung cancer, starting from capmatinib to sotorasib. The first case is a 45-year school teacher who came to me in 2014 with dyspnea, pericardial effusion, pleural effusion at a general hospital. Fluids showed an adenocarcinoma. So she was started on a pemetrexed based. So few post cycles, so you can see the patients. There was a response by this time. So exon 19 came positive. So this is 2014. So we were with the first generation drug, gefitinib. He showed a response for almost 2 years. Again, progression. The patient was re-challenged with, again, pemetrexed-based treatment. So again, she continued to have a response, and by the time she had a brain metastasis, so received radiation, and you can see through AstraZeneca MedGenome, so this repeat biopsy came positive for T790. She was advised osimertinib, but could not take, so she was started on pemetrexed based again. So after 2 years, so this was the third time. So she had a COVID, got admitted. So in this time, the treatment got delayed. Then patient had a bone metastasis for which she received radiotherapy. So this time this is the third time we did the biopsy. So you can see the biopsies showed high PD-L1, exon 19 positive, T790. And this time she was started on osimertinib, but she could not take the drug for more than 2 months and she passed away. So this was from 2014 to 2021. So second case is a 54-year female who came with an abdominal symptoms, in 2017 referred from a gynecologist, and subsequently this patient was diagnosed to have an invasive herediform mode. We can see on almost 1,65,000 of beta HCG. Then see this patient underwent a THBSO in May 2017 and started on a low dose protocol for GTD. So this patient had a response. So the patient was doing fine on evaluation. So abdomen was fine, but CT thorax showed a lung lesion. You can see a 31 into 23 millimeter, and this was persistent. So on 3 months follow-up, so we did see that the mass was persisting. By this time, the beta HCG was normal. So we thought that let us see. So if this lesion is different, and we did a biopsy from this subsequently, and it turned out to be adenocarcinoma. They went to TMH, got operated, early lung cancer, followed by 4 cycles of adjuvant chemotherapy. So 2017 to 2020, she was absolutely doing fine. She just followed up in December 2020 with CNS symptoms, loss of appetite. You can see, so ultrasound showing a swell in the liver segment, high CEA. We checked the beta HCG, which was normal, and the PET CT showed there multiple sites of metastasis, including brain. And we did a cell-free DNA for EGFR. So this showed an exon 19, and she was started she received a radiotherapy because she was symptomatic, and she was started on osimertinib in January 2021, and now 2022 March. So she absolutely in remission with multiple sites of. So this was, we have not done T790 because this patient continued to have a response almost for 15 months or so. The third patient is a 50-year gentleman who came again in 2014 with a chest wall mass with a pleural effusion, dyspnea, got admitted in nearby hospital, worked up, and you can see this FNAC showed a small cell lung cancer. So the biopsy was not done, so IC was not done. So he was started on your extensive small cell, etoposide cisplatin, good response, then radiation, then had some oral metronomic therapy, and this went on for 3 years or so. And 3 years, so this patient had an oligoprogression at times. So at 3 years, when there was a profound progression symptomatic, we did a biopsy. So the initial was a FNAC based on small cell and received etoposide cisplatin, then oral etoposide, cyclophosphamide, then irinotecan based treatment. So this time it turned out to be a metastatic adenocarcinoma. So we did a EGFR CAL mutation. So the coupons were there, as you can see. So T790 was positive here. The patient was advised for osimertinib but could not afford pemetrexed carboplatin. And then the patient had a response to PEM carbo and then went on to maintenance therapy. And on this time progression, so we concealed for osimertinib. So osimertinib he took for 3 months, but CT thorax shows progressive disease. We did a rebiopsy at that point of time in 2018. So we were running a CANSCRIPT study. So we did a CANSCRIPT study. You can see these are the options. So these were given for the CANSCRIPT study. And this patient showed a high score for vinorelbine and carboplatin and etoposide and carboplatin. So probably the small cell component still continued, and he responded to the again etoposide. So almost in these 5 years, he received etoposide based treatment for almost five times. Again, oral etoposide, then post radiation, then subsequently nothing worked, and we lost the patient after 5 years. So the extensive small cell 5 years. So I accept that the biopsy or ISC was not done in 2014. So we know about transition from as non-small cell to small cell, but this was a small cell to non-small cell. Almost 10 lines of treatment without any immunotherapy because looking at the financial condition. So mutation positive. So this was T790, but osimertinib and the first generation gefitinib did not work. Bevacizumab worked, so he was put into one of the bevacizumab trial. Repeated etoposide and platinum always worked for these gentlemen. So this is another case, so which we saw in 2011, and so this is an LIC employee, non-smoker with an effusion, dyspnea, and biopsy done. So this case, so I add you to Dr. Tcentm, who has been with this patient. We both have been there for last 11-12 years now. So initial T790 exon 19 positive, but the patient was started on PEM carbo at Mumbai. Subsequently, he could not tolerate allotinib. Every time you give allotinib, so grade 3 toxicities. This gentleman went on to do well with pemetrexed over almost 3 years of pemetrexed maintenance on a progression. We did a repeat biopsy. So this time T790 came positive. So you can see T790 positive, deletion 19 positive. The patient is on osimertinib. So almost this patient is on osimertinib for 5 years. Now, so this patient has again progressed last month. So after 5 years of osimertinib, in between, he has received some chemotherapy, but osimertinib has been continued. So this on 26th March, you can see, so we got another biopsy done. So this time that Dr. Lal Stupan, you can see this patient has now retained exon 19. You can see the non-friendship deletion. And now he has an exon 20 also. And you can see COS 797 and T790 both with a PDL1 of 5 to 10%. So we also talked with Dr. Tcentm. So he told that we can continue with the osimertinib, and now we have restarted this patient on a PEM carbo. So we don't know have we done the right thing or not, because if we take exon 20, so the drug is not available with us. So we can take Ullah's opinion and from the house, rest of the people, so they can suggest what best to be done. The patient is in PS1, though he came last month with dyspnea and bone pain. This time he has a bone lesions too. So we have added zoledronic acid. Today, in fact, he came for the second PEM carbo with zoledronic acid. He's much better. So as of now, he's continued with osimertinib and restarted PEM carbo. So this is maybe the 6th time he's exposed to PEM carbo in last 11-12 years. Thank you so much.
Thank you so much, sir.
Thank you,
would like
Doctor,
to
for that,
ask.
Thank you so much for the session, Doctor. Now the session is open for any questions. So we would like to invite any questions. You can even put it up in the chat box, or you can ask the doctor on it, or you can even park your questions for the panel discussion later.
So I think Dr. Soumya is back. So if he's ready, then we can have his presentation.
Yeah, thank you, and sorry for the technical glitch that I had. So after the
No problem,
talk,
Doctor. Yes, no problem, Doctor. Welcome back. So you can carry on with your session again. So people who've had any question with the previous doctor's session, you can park your questions for later. Let us continue with Dr. Soumya's session.
Thank you. So after the two beautiful talks by Ghansam sir and Ullas sir, we'll discuss the challenges in detection of Tcentm mutation post-progression. So what is the real challenge that we see? For that, we'll discuss the T790M experience, our own experience, and what are the challenges for the biomarker testing, what the feasibility of rebiopsy post-progression, and the tumoral heterogeneity that can affect the tissue testing results, and early testing, whether it helps or not, and then I'll conclude my talk. So this is the T790M test data that was aggregated from the Astra team. 14 samples, 7 had positive. This is the overall result. This is close to 50%. And out of them, 11 were blood samples and 3 were tissue samples. And out of the 11 blood samples, we had got 5 positive results. And out of 3 tissue samples, it was 2 positive results. So among the patients, 50% was inconclusive and rest 50% were positive. So we'll see the challenges. Next slide, please. So this is this is a paper that was published in a Scopus Interest Journal, Oncology and Radiotherapy. This was published on 10th of March, hardly around 14 days back. This was from our team. We had given a thesis to one of our PG radiology student, and he had done thesis. So the methodology was that we had aggregated 66 patients of non-small cell lung cancer patients, and out of them we lost 12 patients on follow-up, and 54 patients were eventually had a recurrence or progression of the disease, which was documented with a CT scan. Next slide. So coming to the patient characteristics, the site of disease recurrence or progression. So 46 had a lung involved. So it was lung plus minus others. So it 46 were a pulmonary recurrence, and other site without lung lesion was 8. So bone and brain. So there were 8 patients. And regarding the location of the lung lesion, it was across all the lobes of the lungs and in both lungs. Next slide. So what we looked at was that the 46 patients that had a pulmonary recurrence or a lung recurrence or a progression, we did a study on those patients. So out of 46 patients who had lung lesions at recurrence, rebiopsy feasibility was looked at. So rebiopsy was performed in 39 patients, and 7 patients did not undergo the biopsy due to a poor performance status or difficult location of the tumor, or the patient refusing for the test. So out of 50 of 4, we had come down to 46, and out of 46 again 39. So 15.3% did not agree. Out of 39 patients who underwent, go back, previous slide please. So out of 39 patients who underwent a needle biopsy, adequate tumor tissue could not be obtained in 4 patients. So the adequacy rate of obtaining tissue sample was 89.7%. So out of 39, 35 patients we were able to do a tissue biopsy. Next slide. So this is the inverted pyramid that shows that 54 had a recurrence, and out of them 46 had a lung recurrence, means there were tissue accessible from the lung. However, we could do a biopsy only in 39 patients. So it narrows down from 54 to 46 to 39. And out of the 39 that biopsy was done, 35 had adequate tumor tissue. So we can see in the practical world that actually the numbers are coming down if we look at a tissue biopsy. So overall tissue biopsy failure rate was 35.2%. So 54 comes down to 35. This is the overall tissue biopsy failure rate. So what we did is that in those patients, these 19 patients who failed a tissue biopsy had undergone a liquid biopsy. Next slide. So we looked at the literature, and in the literature also we found out that tissue biopsy is not always feasible, and it was 9 to 18%, and overall tissue biopsy failure rate is close to 43%, and we had in our study it was 35%. So we had complications during the rebiopsy. Next slide. So this is one of the case in our CT room that underwent a biopsy, and patient developed a post-procedure pulmonary hemorrhage. Next slide. Again, we had some amount of minimal pneumothorax, and case fatality due to a procedural fatality was 0. We did not have any fatality or ICU admission due to a procedure. However, a patient required monitoring and oxygen, high flow, and a repeat CT scan sometimes. Next slide. So this is the complication in the rebiopsy performed in relapsed cases of non-small cell lung cancer. Pneumothorax out of 39 had 5 patients had developed a pneumothorax. Pulmonary hemorrhage 4 patients developed, and hydropneumothorax 2 patients, and without any complications 32. So 82% was the patients without any complications. The rest of the 18% patients developed either a pneumothorax or a pulmonary hemorrhage or a hydropneumothorax. Next slide. Coming, though this was not our primary intent to look at a tissue biopsy versus a liquid biopsy, however, we did look at that. Mainly, we preferred a tissue biopsy instead of a liquid biopsy because of the PD-L1. So by the time we had done the study, it was 3 years back, and 1 year back we had completed the study. At that time, the PD-L1 significance was not much, and patients were not taking the IOs. So at that time, when patient had a recurrence, by that time the PD-L1 had a significance, and we had allotted one of our students for a PD-L1 as a thesis. So we insisted on a tissue biopsy more than a liquid biopsy. So we looked at the p-value. Definitely the numbers are very less to compare that, but the chi-square was not significant. Coming to the tumoral heterogeneity, it can affect the tissue testing result. Heterogeneity can occur within the same tumor, that is intratumoral variation, and again between metastatic sites it can be intertumoral as well. And heterogeneity can lead to a negative biopsy result, and that may not represent the T790M status of a patient's disease. Next slide. So early testing for T790M patients and their physicians are always anxious to know as soon as possible whether disease has progressed or not. And conceptually, we know that the circulating tumor DNA may be derived from the primary tumor, and it can be derived from the metastatic lesions, or you can have a circulating tumor cells as well. And the fraction of cell-free DNA that is derived from the tumor has a variable contribution. It can range from 0.1% to more than 10%. So we understand that we have got the, at least in T790M, we have been using a cell-free DNA from the Astra coupons or a pharma-driven coupons, and it has been very useful in patients who are not able to undergo a tissue biopsy. So whether if we combine a tissue biopsy plus a liquid biopsy, whether it gives an extra benefit or not, still I think we require more stronger data. We are not practicing right now, right that one. Next slide. So early testing, as Ullas sir was mentioning too, whether if serial testing looking frequently at T790M and then picking up the mutation, it is still a real challenge. Data is emerging that we can go and find out. Suppose some patients who have got a oligometastasis or say clinically not progressive but radiologically progressed. So looking into the T790M serially, whether it helps or not, that is still under evolution. Next slide. So concluding my talk, rebiopsy feasibility and tumor heterogeneity is a common challenge. Reflex tissue testing is to be ordered in all the rebiopsy feasible patients. So you have done a tissue biopsy negative, go for a reflex liquid biopsy. And early testing for T790M mutation is a real challenge. There is a correlation between the level of circulating tumor DNA to tumor burden, stage and cellular turnover. Repeat testing to be done for inconclusive reports, and inconclusive report can be minimized by ordering the T790M at the appropriate time. Thank you.
Thank you, Doctor, for the session. And we would like to welcome any questions now.
I think Intazar Ali has a question. He has raised his hand.
इंतजार अली को इंतजार करने दो फिर.
So इंतजार तो हम कर रहे हैं ना. In that,
Yes, any questions?
So if there are none, can I ask, since I'm going to moderate the next one, Dr. Ghanshyam, can we put around your case and then we can discuss that first, and then we can discuss Soumya's thing, and then we can go to my discussion?
Yeah, please.
So can you, with your permission, Fatima, can we start the panel discussion? We are all friends here. You don't
Yes,
need to
of course, Doctor. Of course, Doctor. You can go ahead with the panel discussions. To the audience, I would like to say that if you have any questions, please park it for later, and let us begin with the panel discussion. We do have time, so you can have your questions saved for later also. Doctor, it's over to you.
Fantastic. So I will, I think my panelists are Dr. Ghanshyam, Soumya, Dr. Sairam, Dr. Vivek, and Dr. Suruchi. So before I start my panel discussion, can I ask Dr. Ghanshyam, what was your case, and we can discuss that?
So I just want to make sure all the panelists are over here. Just
Dr.
a quick check before we start with the panel discussion.
I think Partha Sarthi also was there. Partha, are you here?
Yeah, I am here.
Yeah. And
right.
Dr. Vivek,
let me just invite all the panelists to the panel discussion, and we can start it with that.
Dr. Vijay Agarwal is there?
Yeah, hi Ullas, I'm there.
Yeah, hi Vijay. You are not seen. Maybe that is the reason, because you think that the attention will get diverted from the panel to you. The entire attention is diverted towards you. That is why. Okay, Dr. Ghanshyam, can we start with your case? And then
so actually, I presented 4 cases. So let me start with the interesting case.
The second one, the exon 21. Or whatever your the things were.
Last case where Senthil was involved, the big boss was involved.
The big boss was involved. So whatever Senthil did was right.
So this was in 2011. So advanced lung cancer, non-smoker, exon 19 baseline. So he was started on PEM-carbo and later on switched to erlotinib. Every time you start grade 2, grade 3 toxicities. So he could not tolerate anymore. So anyway, so he went on to take almost 2-3 years of pemetrexed maintenance. He had a progression. This time it showed exon 19 and T790, right? So by that time it came, so he was started on some chemotherapy. So, and then this patient went on to be taking for osimertinib for 5.5 years now. Wow. In between, he had 2 or 3 times, we can say, oligo progression. So every time either there was some or the other treatment. So otherwise a good performance status. For after almost 11 years now, so 2 months back, he was symptomatic with dyspnea, bone pain, and this time it picked up. There is a effusion. There are multiple bone mets. So he again went on to Tcentm. So Tcentm asked for a self-treatment liquid biopsy, but I counseled them for a biopsy. So I will counsel them for a biopsy. So this time it is exon 19 positive, exon 20 with CYS74 and T790. So he has been continuing on osimertinib. We have started on PEM-carbo. He in fact came for the second cycle. He's symptomatically better. So now we don't know. So should we continue this, or so this is the 6th time he's receiving pemetrexed based in last 12 years.
Okay. Dr. Vijay, any takes, any ideas on that? I'm sure managed wonderfully, but your thoughts.
Yeah, I mean, super, man, to get that kind of survival in lung cancer. Historically, it's been kind of unheard of. So well done, the team. Well done, the team. I have nothing else to add. I am not entirely sure that giving osimertinib along with the chemotherapy is giving some added benefit to it, and whether we should just give the chemotherapy and possibly reinstitute osimertinib if you failed after the chemotherapy. Very limited data for concurrent treatment, but I don't have a viewpoint one way or the other.
Okay, Dr. Sairam, sir, your take?
Yeah, we find few patients tolerating pemetrexed for at least 2 years, but more than that we have not seen. So probably if the patient can tolerate, probably we can continue with pemetrexed.
Soumya, the young gun.
Sir, so the variant allele frequency in compound means multiple mutations. The significance of that sometimes has to be looked at, and actually,
one second, Soumya. Before you say, can you, Dr. Tcentm, can you please pull out the NGS report? Maybe Dr. Suruchi is there.
I'll show.
Yeah, so till the time Soumya can give us comments. So Dr. Suruchi is there. Maybe we'll ask her to comment on that. Maybe she'll make sense of the molecular pathology report, which we won't be able to. Yes. Okay, that's Dr. Soumya. Go on.
I would like to see both the reports, the previous one and the latest one.
That is the problem with the molecular oncologists. No, they will come to this and they will tell us what we did was wrong. No, it's always great to have a molecular pathologist on board. Yes, Dr. Suruchi. Yes, Dr. Suruchi.
Okay, so tumor content was 40%, and for exon 20 missense mutation, okay, this is again a resistance, 7% variant allele frequency, and exon this is at 25%.
The T790 is at 25%.
And driver is at 64%.
So 7 is only for the exon 21.
Yeah, because it is a new development, and maybe a clonal population is having it. But driver is largely at 64%. So obviously the progression is quite high. And again, this T790M is 25%. If we have the previous report, what was the previous T790M?
Dr. Ghanshyam? No, this was a normal one. This was just the RT-PCR.
Just the, okay, qualitative.
With the qualitative listing. Okay.
Yeah. So if we could compare it with the earlier variant allele frequency, it could have been
report of 2014, 11.
Okay. So, but now it is clearly showing that 797 codon mutation is building up in some clones. It is a clonal heterogeneity, and obviously driver is at high, so there is a high progression.
So again, what Dr. Suruchi said, I would totally agree with that. The wonderful the way she started. The first thing she said was the tumor content for 40%. That's a fantastic thing. Then the second thing which we have to look at is the VAF. So 64% for the driver, 25% for T790M, 7% for this. Dr. Suruchi, is this the exon 20 mutation, is this the amivantamab or the mobocertinib or the other one? I mean, can you throw some light on that? If you can.
It is not mobocertinib. That is exon 20 insertion mutations.
Insertion. This is a mutation.
Yeah, it's a resistance mutation. It also causes resistance to TKIs.
Okay. So then in that case, I think what we are doing is, Dr. Ghansham is the right thing. So we had Flora 2 trial at our center, not with me, Sumit had that. The tolerability was an issue with PEM-CARB and osimertinib. But people did tolerate and the results were good. But that was a de novo setting. So just in case the patient is not, and you said with chemotherapy, the patient is doing fine.
Absolutely. So back for the second cycle today, is absolutely doing fine.
Yeah. So then I think, Dr. Ghansham, the point is, let's continue with chemotherapy. I mean, you don't change the winning combination. Right. So to me, let's just continue with chemotherapy. I'm not a big fan of chemo plus TKIs. And I know Kumar hates me for that, but that's the way it is. To me, it's either chemo or TKI. And, so what I would do probably is give chemo. At the end of 6 cycles, put on pemetrexed maintenance once again, do a liquid biopsy at the end of 6 cycle, see what is happening to the VAFs of everything. Maybe put him onto afatinib or osimertinib again once the chemotherapy fails. That is what I would do. Dr. Sairam or Dr. Vivek?
Yeah, if chemotherapy is no more working, probably, but we can try with TKI, I think. Our patient is not tolerating.
Yep. Dr. Vijay?
So, Dr. Lassa, one of the other things we need to consider, and this is purely for academic reasons, because Dr. Ghansham already mentioned about cost issues for this patient, but ABCP regimen is another option for a lot of our patients, that Atezobev, carbopacli. If patients have previously received carbopem and you would be concerned, then that would be another combination that you would consider.
True. I think ABCP is good, but my point here, Vijay, I wanted to say that was, but with such a high, EGFR and T790M, and the major benefit of that was basically in patients who had not got a T790M. So I think with the driver still being at 60 and this, I would probably go ahead with, I would like to probably keep ABCP somewhere down, lower in my list. That's just a personal point of view. So that was fantastic, Dr. Ghansham. Thank you. Dr. Soumya, you also had a concern which you want to discuss in the talk, right?
Yes, regarding the first was the RT-PCR, now it is the NGS. So the variant allele frequency right now, the exon 20 missense, whether that was there originally or not, because it is not an insertion mutation. We don't know.
No, you had in your talk, you had this thing between the liquid biopsy and tissue biopsy.
Yes, sir. Yes,
so
sir.
what is that concern?
So, sir, that one actually, we had looked at the feasibility of a rebiopsy in our main study. So the rebiopsy part, we saw that the 35% was the tissue failure rate. So that was it. And the numbers are very small to compare a tissue biopsy. We did a 19 patients liquid biopsy, and we had 34 patients with a tissue biopsy. So 34 versus 19. But mainly the reason for tissue biopsy at that time is that the PDL1. So initially, we did not do the PDL1 for most of the patients. So when the patient had a recurrence, by that time the immuno-oncology was available and the PDL1 was actually being done for everyone. And one of our DM thesis student was doing a PDL1. So we tried to get a tissue biopsy. Mostly that is the reason we went at tissue biopsy. Okay. So the chi-square did not show any difference between the tissue versus the liquid biopsy.
I think the numbers are too small.
Yes, sir.
So, in these small numbers, we should not really be commenting on that. So can I now share my screen? Okay, let me see. So very simple questions that I probably have here. And I'll just, okay. So this webinar is basically about the T790M mutations post-progression. And I have with me Dr. Soumya, Dr. Ghansham, Dr. Vijay, Dr. Sairam, Dr. Partha. Partha, you have been very silent. And Dr. Suruchi. I'm sure Dr. Suruchi will have a huge role to tame all the medical oncologists here. So let's start with the T790M conundrum. Let me start with Dr. Partha Sarthi. Dr. Partha Sarthi, is the question relevant today? When they asked me to do a talk on T790M, in my last 2 years when I've given like zillions of talks, nobody has ever asked me to do a talk on T790M. I told them, this is the 2016 topic. Why are you asking me now? They had answered. So what percentage of your patients are treated with osimertinib in the first line? Partha, KMP?
Most of them, probably around 80% of the cases.
Wow, that is why Delhi is called a rich state, man. I don't know which Delhi, India is a country of this thing. Fantastic. I am getting jitters, Partha. Okay, let me go to Soumya.
So I think most of the patients are not yet able to afford the osimertinib. So
they must be going to KM Partha Sarthi. That's a ballpark figure.
To Bhutan.
Okay, no, but just a ballpark figure.
Yes, sir. So I think that 30% only will be able to afford.
20 to 30%. Fair enough. Dr. Ghanshyam?
Yeah, same thing. Same place, same.
Same place, same this thing. Okay, 20 to 30%. Vijay, the IT capital?
Yeah, about 60 to 70%.
Vijay, I could not hear you.
About 60 to 70%. So the vast majority of them do. Yeah.
Vast majority of them do not.
60 to 70% of them would end up with.
Okay. Dr. Sairam, sir?
I think I am from government regional cancer center. I think hardly 10%. Sir.
Hardly
At
10%.
least the patients coming there are all poor patients. Only few CGHS, ESA, railway, those patients only we dare to start on.
True that, sir. So basically the question of T790M testing is very relevant. I mean, I'm sure we had a lot of debates about the flora and the other one. The question actually has to be about T790M. How many patients? I'll start with Dr. Soumya now. How many patients actually take treatment in the second line? Let's say you have given either first line TKI or second line TKIs. How many patients take treatment in the second line, Dr. Soumya?
So patients who are on TKI, most of the patients they are able to take a second line.
A second line. How many? Ballpark figure.
So those who are on TKI, they almost 90% of them, I think they will take a second line.
Okay, Dr. Sairam sir, in comment setup.
Very few patients will have some good result, and I feel they progress very fast if we don't start them on chemotherapy. I feel, sir.
So by and large, sir, how many people take a second line treatment?
Very few. This only except in this reimbursable sector or insured patients, very less. I think 5-10%.
We are coming into a country of contradiction, sir. I hope the government doesn't arrest me like Veerdas, because India is we are getting extreme views over here. Okay, Partha.
Almost all of them take the second line. If you are asking about the cytotox,
I am joining Metro. I'm telling you, I'm quitting from Rajiv Gandhi now. Okay, Dr. Ghanshyam.
2/3 of the patients, 60-70% patients.
60-70% of the patients. Vijay?
80% would go on to second line.
Okay. So what I did, and since we have a large number of lung cancer patients, so my take on this is people who have got a T790M positive, a lot of people will take treatment to the tune of 85-90%. People who T790M actually positive and then you offer them chemotherapy, not more than 50 to 60% actually take treatment. So a lot depends on what the test results actually show it across over there. But the quoted literature is what Dr. Ghanshyam said was very right. Only 2/3 of people will take treatment in the second line. So this is the important thing. So we are talking about non-osimertinib. So I am not going to ask Partha any question over here because Partha does not believe in giving first and second generation TKIs. So what are the patterns of progression? I'll start with you, Dr. Sairam sir. What are patterns of progression following treatment with first or second generation TKI or the KN regimen, as I commonly call the Kumar Naronoha regimen, the TMH trial regimen? What is the pattern of progression? A lot of people have intracranial progression, extracranial progression, both of them. What do you say, sir?
Both of them, sir.
Both of them. Both of them is the predominant one. Okay. Soumya?
Yes, sir. Again, we see both of them, but means extracranial and then comes intracranial.
Okay, extracranial then intracranial. Fantastic. Partha, just in the 10% of people that you see here.
Yeah, if you have not used osimertinib, then intracranial progression is very, very common.
Okay, very, very common. Dr. Vijay?
Yeah, I mean, it's both really. In our practice, baseline MRI brain has become a standard of care now. So we do pick up a lot of intracranial mets upfront at the time of staging itself. And if you're giving them first or second generation TKIs, they end up with radiation. So we are quite insistent on trying to treat the brain mets quite early on if you're not giving them osimertinib. But we see both, which is fair share.
So again, we did a study on that. 20 to 25% of people will have only an intracranial progression if you give them first generation TKIs actually without any extracranial, and this will have huge implications as far as the T790M testing also is concerned. So that brings me to the crux of the matter today. What percentage of patients are tested for T790M? I'll start with Vijay. How many people do you test for T790M post TKI progression? Obviously non-osimertinib.
Non-osimertinib. So we test all of them. We test
100% people. So you offer them 100%. Do all of them get tested?
No, but 80% of them do.
Okay. Okay. Dr. Ghanshyam?
Yeah, so 70 to 80% probably does it. Rest they go to shop for another.
They go to Tcentm for another opinion. Okay. Dr. Sairam?
Around 50%, sir. Those who are educated a little bit and those who can manage this testing part and wait for some, wait for treatment. I could test 17 patients, sir.
So the testing is done in-house or the testing is done, you outsource it, the coupon testing that I usually call it as?
It's all coupon testing only, sir.
It's all coupon testing.
Yeah.
Soumya?
Yes, sir. We do offer to everyone. We get it done in around 80%.
Okay, so around 70-80% are tested for T790M. So this is a question. You have a patient of stage 4 non-small cell lung cancer. He's on second generation TKIs. The PET CT scans shows stable lung disease, but there's a mild progression in bony disease. Will you test for T790 testing or not in this patient? I'll start with you, Dr. Soumya. So patient 9 to 10 months, normal PET scan ke liye aaya, and interval changes as our nuclear medicine people are very fond of saying.
Yeah, so that is the reason that we hate the PET scan sometimes, especially when it detects increased metabolic activity, but no. Yeah, so it becomes. So most of them.
It is called ICTPD, IC towards progression, and I feel like banging my head against the not my head, the patient's head against the nuclear medicine guys. So
what we do is instead of a 3-monthly PET scan, maybe I'll prepone to a 2-monthly, but still keep them on the same drug that I do.
So you do treat beyond progression, and your patients don't go to Ghanshyam or Senthil?
Apprehensive and anxious patients will go, but I'm happy with that.
Okay, you're happy with sending this kiri patient somewhere else. Okay, Partha, what would you do?
If it is mild progression confined to bony lesions, I'll wait.
You will wait. You will wait for the disease to come, and and the patients don't go anywhere else. Your patients anyway don't go anywhere else. Okay, Vijay.
I would do the test, but I'm not sure I would change the treatment.
So you will do the test, but you will not change the treatment.
Yeah.
Cardinal rule, Vijay. The patient, let's say the T790M comes positive, and the patient will say,
"Yeah, if it,
how do you get the testing done?"
No, what I'm saying is that I would not change the treatment to a non-TKI regime. I would not switch it to chemotherapy.
If it comes as positive,
if it T790 comes positive, I'll switch to osimertinib. Okay, if it comes negative, then I would probably just say push it on for another 3 months.
And will you then do what? So, one thing which I have emphasized again and again in my talk over there was a value of repeated liquid biopsies. The data looks very promising in the article that I read. In my own practice, very few times I have seen that people who do not get a liquid biopsy negative first, they turn out to be positive, and patients have a lot of reluctance because the test does cost money.
Yes.
So will you, let's say at this patient, you have a T790M done, which comes as negative. In 3 months' time, there's a good progression. You ask the patient for T790M testing once again. Patient says, "Give me 10,000 rupees, I will do."
Fortunately, I don't have that problem.
Okay. So no, but the point is, are the patients comfortable?
Yes.
You will do it again?
I would do it again. Yes.
Okay. And what has your experience been? Have you picked up more?
It's not a situation I come across on a regular basis where you have mild progression and things like that.
Okay.
Or I need to do repeated testing. Most of the time, it's quite obvious progression, and then we test it. I mean, yeah, I think across the bridge, if it comes to that if clearly if there's a repeated testing and it's positive, we will have to switch, won't we?
Okay. So, Dr. Ghanshyam, what would you do?
So I can share my case, what I have seen today. So that will be then you can answer my question also. So I have a gentleman which I have seen in January 2017. So non-smoker adenocarcinoma. So
Can I shift to your place also? I mean, except for Rajiv Gandhi, everybody seems to have a 10-year follow-up. Partha is giving OC material to everyone. Vijay won't take me. You know, maybe I can come to your place and get practice over there. Tell me.
So this patient has now completed 5.5 years. So 2017, he was put in a PEM carbo and bevacizumab trial. So post 8 cycles, he had a response. So he had a intraocular disease also.
Okay.
And then subsequently, he was put on erlotinib. So he completed 4.5 years of erlotinib. So he had a fall some time back, and today we did a CT thorax. So CT thorax is showing a primary mass, which is by RECIST, it is 55% increased.
Okay.
Right? So by RECIST, 55% size is increased. Otherwise, so it looks like an oligoprogression.
Okay.
In between maybe 2 years back, we did have T790, it was negative. So again, he had some 20-25% progression, but he continued beyond progression. So completed now almost 4.5 years of erlotinib. So should I now, though he's asymptomatic, he has just come for a regular follow-up. And this time, the mass is showing a 55% radiological progression in the primary side, though there is no other side of disease at this moment.
So, Dr. Ghanshyam, what I would do is probably I'll ask my radiation oncologist colleagues if this can be included in the field of radiation without any significant problems. If it can be, I would do a biopsy. We have now got some 12 or 13 cases of small cell transformation. I have already given it to Indian Journal of Cancer for a publication also. So SCLC transformation also is very, very important that we need to. I think a 55% increase by RECIST does in the primary site and not in a bony site. But we can treat the oligo progression actually. And maybe you will get your, things right. My point actually comes if you send for T790M, that also comes positive. And this is also amenable to, to RT, then what would you do?
So I actually sent for a radiation opinion, and I thought today we have a meeting so we can discuss about T790 actually.
Yeah. So I think if the radiation therapy is being given, I will not change. Because then I don't need to change the point is I will do the test only when I want to change the treatment. That's the take home message that I want people to say.
Just in your talk. So I really like that. So yeah, absolutely.
Okay. Fantastic. Dr. Suruchi, I'm just coming to you in another in some time. And in our practice, I think all of us follow treatment beyond progression. That is absolutely okay. So what are the common challenges that we face in so let me ask the molecular pathologist now. Let me take the two perspectives. One is the medical oncologist perspective and one is the molecular pathologist perspective. So Dr. Suruchi, what do you think are the challenges that you face in liquid biopsies for T790M detection? Let's hear that side of the story first.
So mainly liquid biopsy testing will come out to be negative for T790M only in cases where the tumor would not have shed enough DNA or tumor is not that much progressed. So there,
can I just stop you for a second and ask you to place a hand on Geeta and say, do you write that in the report? Either tumor is not there, and do all of your fraternity writes it over there?
No, we don't do that, but we have done the validation and we do look at the cases on case-to-case basis. And I do personally call the clinicians and ask if the patient is on PKI and how much time he has been. And even not only NGS data, so we just check whether any signal is picked at that position on NGS. So even if we get the mutation at below our reporting criteria, we would call and we would send it as a custom message to the doctor that we are detecting a signal, but it can be a false positive. So even if it is building up, so and we are seeing a signal, so we do that way. So this is the challenge actually.
I'm going to drag you on this. No, tell me you now.
Dr.
Not drag
Ulas,
you.
Dr.
Yes,
Suraj,
Dr.
yes.
Ghanshyam. Okay,
Dr.
Dr. Ghanshyam is there to argue first. Okay, that's
Suraj has
okay.
never called us. No, never called us.
So Ruchi, see, I am from Rajiv Gandhi, so I anyway announce lab. But Dr. Ghanshyam says you have not called him.
Yeah, because I have
All the
started
samples
this
are good.
position recently.
Oh.
And
Okay.
custom messages we have been sending
Okay.
through
No,
mails along with the
Dr.
reports.
Dr. Sarojik, I have a point. Where in the molecular pathology report of the T790M, and I am talking right now. See, if we send for T790M, we'll send by RT-PCR, right? Either it's a COBAS or something. In that, where is it written that the ctDNA quantity is not sufficient?
No. Actually, I was talking about NGS report.
No, I am talking about because we don't send NGS for everybody, right?
Yes.
So if a person
So
has,
no, we do not check for the ctDNA quality, because DNA quality for cfDNA is usually good only. It is not a challenge like FFP DNA.
So it is
just
a very basic question, Dr. Sarojit. Sorry for my ignorance. I just want to get my facts all right.
Yeah.
So let us say the concept of non-shedders, which we had spoken. So there are certain tumors which are non-shedders. So you know what happens is, let's say the lung disease is totally under control, 1 centimeter, 1.5 centimeter, some amount of DNA, some amount of increase in bony disease is there, which may or may not be significant. How do I know whether my tumor is shedding adequate amount of DNA for you to detect T790M mutation? That's all that I want to know.
Yeah, that is a tricky question.
That's a very easy question. Tell me, Vijay, you want to join the fun?
Yeah, I mean, you can't know, can you? I mean, obviously, if there are multiple sites, then the likelihood is higher.
Yes,
But that is why if a liquid biopsy comes as positive, you take that as positive. But if it comes as negative, a case can be made of doing a tissue biopsy if accessible.
I think that is the point that probably I wanted to put across over there. You know, the right time when I showed that was a very nice slide that I made myself. Rest of the slides were copied.
Yeah, that slide was very nice. That 4 things that you have mentioned, the right
time, the right test, the right interpretation of the test, and the right radiological way to do. You know, I mean, I will not send. So a lot of times, I have learned, it's not that I have not, I have burned my fingers and I have burned my hand and everything. So a patient had a small 2 millimeter, 5 millimeter lesion in the brain. We sent a liquid biopsy and the remaining disease was inactive. We sent a tissue liquid biopsy, that report came as negative. There is no point. If it was positive, probably I could have given OC Mertenant, but then if it is negative, probably the tumor is not shedding good enough DNA. But as medical oncologists, we would like to ask you, Dr. Suruchi, is there, I mean, to tell us now for the treating physician, that whether it was a true non-shedder or it was a true negative T790M. That's what we want to know.
See, as you mentioned, at right time of sending the liquid biopsy, that is more important to distinguish between these two things, whether it is a true negative or it is a true non-shedder. Because if it has progressed to a certain level, it will lung cancer is a known shedder. Like we detect ctDNAs for lung cancer, and if it has progressed to a certain level, then it should pick it up in liquid biopsy. So I think that right time is very important. Yeah.
Fantastic. So can I now go to Dr. Sairam and Dr. Soumya? So Dr. Sairam first. Sir, what are the challenges that you face in a government sector from a medical oncology point of view in sending people with T7 for T790M mutation? Liquid, sir, liquid is very easy to send. Why will the patient not accept?
So, but the turnover time, at least from for free coupon, I think it is taking a long time, sir, for the reports.
How much, sir?
It usually takes about 1 month, sir.
1 month.
Yeah.
Okay, the coupon guys should come and meet you more frequently, and I'm sure they are listening and they should come and meet you. Ghanshyam boss, how much time does it come into?
I think in the coupon it takes 8-10 days working days.
8 to 10 days. Okay. So except for the time, Dr. Soumya, what are the other challenges that you face?
No, right now with the ability of the coupon, the challenges have come down. So anyway, if we go and get the tissue, we'll send the blood, means the cell-free DNA. So I think that things have been made easier for us right now.
Okay. So let me ask Partha. Partha, you have been very silent. What are the, I'm asking a wrong question though. You are the OC Mertenant guy, Partha. Next time I have a OC Mertenant meeting, I'm going to call you. So what is the T790M positive in the bygone eras that you have seen before? In the test that you have ordered, just a ballpark.
Yeah, if you are using the earlier generation TKIs, then it must be around 25 to 50%.
Okay, Vijay, your experience of T790M positivity? Vijay, you are muted.
Sorry, about 10 to 25% in my practice.
10 to 25.
Not high, yeah.
Generally, our data, initial data was 48%. It has now come down 54%, but somewhere around 42 to 45 to 55% is what we usually get on a liquid biopsy also. But I think very important is the time when we decide to change the treatment. That is very, very important. This one, this is for everyone. Dr. Ghanshyam, I'll start with you. We all spoke about repeating liquid biopsies. You know, the first time it was brought to my attention, I said, "Har 3 mahine mein 10,000 रुपए patient की वो खर्च करवाते रहेंगे." So, do you send for repeated liquid biopsies? And if yes, what is your results? What has your experience been?
No, we have repeated biopsies, means liquid biopsy, but not at a 3-month interval. So
Okay.
in last 4 cases, maybe after a year or so we have done, but there are literatures which have shown that. So when I read through, then it has shown that repeated biopsy 3-4 negative, and then suddenly it turned out to be positive.
Again, a very important point which Dr. Ghanshyam has put across, and what I will like to say. I'm sure Dr. Suruchi can tell us more about it. And that's my thing. If it is a ddPCR, that is a droplet digital PCR, the sensitivity is very high. So your T790 rate pickup is going to be much more better. The problem with ddPCR, correct me if I am wrong, Dr. Suruchi, is that the reagent is not very freely available now. Exactly. And we have all shifted up to COBAS. With the COBAS, the sensitivity for getting T790M is not that high actually. For the del 19 L858R is okay. So yes. You see, my molecular pathologists have taught me well, Dr. Sudachi, your take on that. So again, for the medical oncologists, we should know what liquid biopsy, which PCR, COBAS, or the beaming or the ddPCR has been sent. Your take, Dr. Sudachi.
Yeah, as you rightly said, of course, there is a challenge in retrieving ddPCR reagents, and we have mostly shifted to NGS, or we are not doing COBAS as such. But yes, sensitivity is a challenge, and like he said, like Dr. Ghanshyam pointed out, that after like repeated 3-4 negatives, suddenly it comes out to be positive. So that is because the tumor has progressed to that level, or that much ctDNA is available, that it is the technique is sensitive enough to pick it up. So of course, yes.
So one very important question to the medical oncologist. See, when we say liquid biopsy term, the liquid biopsy term is used very vaguely. When I was speaking about liquid biopsy in this, I was meaning the PCR, the COBAS, or the ddPCR, and some people may think NGS. So let me start with you, Dr. Vijay. A patient on first or second generation TKI, or the KN regimen that we normally call as, Kumar always has hiccups when I discuss the KN regimen, and the patient progresses. What is the test you order in liquid biopsy? You order a liquid biopsy NGS or a RT-PCR?
We go for NGS.
Oh, so you send a liquid biopsy NGS, or maybe that is why the okay, Dr. Ghanshyam.
This is RT-PCR.
RT-PCR. See, India is a country of Veer Das. I'm going to get caught today. Soumya.
Yeah, so we do send for a RT-PCR, okay. But NGS pickup rate is more.
Fair enough. Dr. Partha?
NGS, I think DDPCR is slowly going out of the way. I mean, it is going to be obsolete.
I am quitting Rajiv Gandhi tomorrow and I'm coming to your center, Partha. I'm telling you, come to Rajiv Gandhi, swap places. Okay. Dr. Sairam, sir.
Yeah, whatever the company offers, because we
whatever the company offers.
free coupons, because most of the patients won't be able to pay.
So let me ask the end user over here, Dr. Suruchi. So out of 100 samples of this thing you get, how many are PCRs and how many are NGS? And what is the turnaround time for both?
Turnaround time for NGS is 14 days. And for PCR is 7 to 8 days, I think. And we do get a lot of PCRs and around 100 of samples a month for NGS on liquid biopsy for, it's a pan cancer number, I'm telling. Lung cancer, I have to check.
Yeah. So we also send for only EGFR PCR once we have a liquid biopsy, which is once somebody progresses on first or second generation, just to look for the T790M mutation. If that comes as negative, then we go for a biopsy and then maybe an NGS after that.
One thing, sorry.
Yes, Dr. Suruchi.
One thing I would like to point out here that PCRs, the false positivity or false negativity rate is higher as compared to NGS. NGS is quite sensitive and robust. And also, since we can look at the real-time data in integrative genomic viewer, so even if our pipelines are not picking up, we just check the data in the BAM files and we see the hotspot positions, whether we are picking up any signals, as I pointed out earlier also. So I would feel like if cost is not an issue, then NGS is better option.
Okay, fantastic. So this is for you, Dr. Suruchi. They wanted me to ask this question. We have discussed it before. I think we have just 2 more minutes before I wrap it up. Any confirmatory methods are able to verify the quality and quantity of ctDNA to do liquid biopsy assay? And I'm talking about both RTP, both PCR and NGS. So for the naive medical oncologists, tell us that.
Yeah, sure. So quality of ctDNA we do measure, the quality of ctDNA is measured by tape station profiles we use. Usually ctDNAs are not very bad quality samples, and quantity that we require is at least 30 nanogram of samples. So that is sometimes a challenge because the blood in Streck tube is sometimes we get it as lysed, which is very rare, but 30 nanogram of DNA we require for ctDNA testing to be proceeded for. Quality is not a challenge for ctDNA samples. I don't see failures, like it should be around 1 to 2% only. In blocks, as you
use the Thermo Fisher or the Oncomine? What is the NGS platform that you use?
No, we are doing it on Illumina.
On Illumina. Okay, fantastic. Okay, and
so we have our pan cancer panel as well as our EGFR panel.
Okay. So how many people, if your T790M is negative, this is my last question, Dr. Ghanshyam. How many do you do a tissue biopsy all the time?
Wherever possible. So you, as we discussed, no. So you need to see those patients who are long-term survivors and progress. You need to see the background histology also. So wherever possible, definitely a tumor biopsy should be there. Otherwise, liquid biopsy.
Dr. Sairam, sir.
If the liquid biopsy comes negative, tissue biopsy is attempted.
Okay, Vijay.
Yeah, I would push for tissue biopsy if liquid biopsy is negative or inconclusive.
Approximately how many patients would you have that?
I would have, if I were to take a guess, it would be about 60% of them would end up with a tissue biopsy.
Okay.
The other 40% is because of not accessibility.
Maybe the only bone lesions and everything. So a lot of things which are there. Dr. Soumya?
We also do pursue a tissue biopsy.
Okay. Partha?
We are preferring tissue biopsy, but if we are doing with the coupons, we are sending a simultaneous liquid biopsy sample also.
Okay, fantastic. So a lot of a high percent of people, 70% of 60-70% of people are doing actual tissue biopsy on that.
Sir, can I ask a question here?
Yeah, sure.
So when you are doing the tissue biopsy, what is the percentage failure rate you are, seeing? I mean, I'm sure that there would be some failure on tissues.
Let Soumya take up this. He did present the data on that. Dr.
Yeah, so we had 54 samples, out of which we were able to do a biopsy in 46, and out of that 46, I think we had 19 patients who underwent liquid biopsy, and rest of the patients, 34, they underwent tissue biopsy. So out of that, I think we had around 5 patients who had an insufficient or means we did a biopsy, but we were not able to get a result.
So in those cases, in real scenarios, like if a patient, you have sent a biopsy tissue and it gets failed, so do you actually look forward for liquid biopsy?
Yeah, we change it to the liquid biopsy.
I think that way, Dr. Saruchi, I mean, most of us, everybody has got a very trained interventional radiologist, and tissue is, although liquid biopsy is here to stay, but tissue is actually not an issue now. The IR guys are so aggressive that tissue to kahin na kahin se nikal hi lenge. But then
the quality of the tissue and FFP embedding protocol that we follow later on, that actually compromises the quality of the DNA.
Absolutely true. So I always feel, I think in an ideal world scenario, I would like to do both tissue and liquid. Because yes, this is what should be done, because something they will catch, something this will catch. This is what an ideal world.
And tissue will represent only a part of the tissue, and liquid biopsy will represent all the clones. So heterogeneity also you can pick up through liquid biopsy, and I think tissue can be done at the baseline if we are picking up, and if we are doing at intervals, liquid biopsy can be followed up.
Liquid biopsy is here to stay. I always say liquid biopsy is like Donald Trump. You may not like him, you may hate him, but you cannot ignore liquid biopsy. This is my slide for today. Actually, I think T790M testing is a marriage between the art and the science of medicine. The science of the medicine, because it's OC Mertenant. Art of the medicine, I think the right time, the right test, the right patient, the right technique, the right interpretation is very, very important. I thought this will be one of the most difficult webinar, the moderation that I will do, but it turned out to be one of the most interactive and fun-filling session. So thank you to all my panelists for bearing with me, and I hand it back to organizers. Thank you.
Thank you so much. This is an amazing slide, the last one, and the end note was really.
Thank you, sir.
Thank you all.
Thank you so much, sir. Thank you all the doctors. I would like to ask to our audience, do you have any questions for our doctors?
They want to know what is there for dinner and everybody's home.
Okay, thank you, sir. Thank you all the doctors. On behalf of IAO, International Association of Oncology, I heartily thanks to all our doctors, especially Dr. Ulyash Batra for his moderating the sessions and all. Thank you all the students and delegates for joining. And I would like to thank especially AstraZeneca and Mertenant for supporting us for the wonderful scientific sessions. Stay tuned with us for more updates regarding IAO webinar and conference. Students can download their e-certificates from IAO dashboard, and feedback link and YouTube link is already provided on that chat box. Thank you all. Good night, all the doctors and delegates.
Thank you.
Thank you.
Thank you, everybody. Thank you. It was really nice to be here. Thank you.
Thank you so much, sir.